Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Breast Cancer Risk for Non-Carriers of Family-Specific BRCA1 and BRCA2 Mutations, Findings from the Breast Cancer Family Registry by Allison W. Kurian et al. My name is Susan Domchek, and I'm the Director of the Cancer Risk Evaluation Program and Associate Professor of Medicine at the University of Pennsylvania in Philadelphia, Pennsylvania. My oncologic specialties are breast cancer and breast cancer genetics, and the title of my podcast is Predictive Testing for BRCA1 and 2 Mutations, the Value of the True Negative. The benefits of genetic testing for BRCA1 and BRCA2 mutations have been increasingly well established. Management options for early detection and prevention exist for known mutation carriers, and these interventions, such as breast MRI, risk-reducing salpingo-oophorectomy, and prophylactic mastectomy, can decrease morbidity and mortality from breast and ovarian cancer. Studies are ongoing on the use of BRCA1 and 2 mutation status to guide treatment of breast and ovarian cancer, with PARP inhibitors as one example. Despite these major advances, an argument can be made that the greatest benefit of genetic testing in families with known gene mutations is the identification of individuals who do not have the familial BRCA1 or BRCA2 mutation. Testing unaffected family members for a known familial BRCA1 or BRCA2 mutation will lead to changes in management with targeted screening and prevention for the newly identified mutation carriers. In contrast, after testing negative for a known family mutation, strategies such as prophylactic mastectomy or oophorectomy, both clearly effective but with significant downsides, need no longer be considered. In the last several years, there has been concern raised that women testing negative for known family mutations, hereafter referred to as true negatives, might have an excess risk of breast cancer, with a relative risk as high as 5 reported. The hypothesis behind such postulated elevated breast cancer risk is the inheritance of low penetrance susceptibility alleles that might be present in the family apart from the known BRCA1 or 2 mutation. Single nucleotide polymorphisms, or SNPs, were identified by genome-wide association studies in the general population with associated relative risks generally less than 1.5, and several of these SNPs have been shown to modify penetrance of breast cancer risk in BRCA1 and 2 mutation carriers. The initial studies demonstrating an increased risk of breast cancer in true negatives had limitations. These included a retrospective design in some and small numbers in others. Subsequently, 2 prospective studies of true negatives have been published, which demonstrated no excess risk of breast cancer. In these studies, published by Domchek et al. And Corday et al., individuals presenting for clinical testing and found to be true negatives were followed prospectively. These studies did not demonstrate an excess risk for breast cancer in true negatives, with standardized incidence ratios of 0.52 with a 95% confidence interval of 0.13 to 2.09, and 0.82 with a 95% confidence interval of 0.59 to 1.5, respectively. The confidence intervals are, however, wider than one would like and do not rule out a 1.5 to 2-fold increased risk. It is in this context that the work of Kurian et al. Will be discussed as a significant contribution to the field. The approach by Kurian et al. Is different from the studies discussed above. Here, segregation analysis is used to calculate the relative risk of breast cancer in true negatives. Population-based case families of the Breast Cancer Family Registry were used instead of clinic-based samples, thus minimizing referral bias. In addition, the breast cancer risk of true negatives is compared not to the general population, such as SEER data, but rather to women and families with breast cancer but without detectable BRCA1 or 2 mutations. Of more than 3,000 families enrolled, 292 families had documented BRCA1 and 2 mutations, and in these families, first-degree relatives were tested when DNA was available. Of note, information on the number of first-degree relatives tested and their baseline characteristics are not reported, a limitation of the study. No evidence of increased risk was observed, with a relative risk of 0.39 and a 95% confidence interval of 0.04 to 3.81. Neither this study nor the studies by Corday et al. And Domchek et al. Exclude a modest elevation in breast cancer risk. However, even if such a risk exists, there are no data to support any screening apart from that recommended for the general population. This specifically applies to women who do not have an independent risk factor for breast cancer apart from the familial BRCA mutation. For example, a true negative with lobular carcinoma in situ still has an elevated risk of breast cancer based on LCIS alone. Similarly, a woman with a strong family history of breast cancer on both the maternal and paternal sides of her family will still be at some elevated risk, even if negative, for the known BRCA mutation in her paternal aunt. The work by Curran et al. Also highlights several other clinically relevant issues. The first is the difference between a true negative and an uninformative negative, and the impact this difference has on patient management. In families with multiple cases of breast cancer, genetic testing should begin with an affected family member whenever possible. If a BRCA1 or 2 mutation is found, site-specific genetic testing for the specific familial mutation can then be performed in unaffected individuals. True negatives revert to population screening, while mutation carriers undergo intensive screening and prevention strategies. In contrast, if a BRCA1 or 2 mutation is not found in a family with multiple cases of breast cancer, this result is uninformative. We do not know the genetic cause of the cancer in the family, and a negative BRCA1 and 2 test is not reassuring in terms of breast cancer risk. As Curran et al. Nicely demonstrate, the first-degree relatives of BRCA1 and 2 negative breast cancer probands are at elevated risk for breast cancer. The magnitude of this risk can be estimated by using breast cancer risk prediction models based on the specifics of the family history. Individuals in these families may be eligible for more intensive breast cancer screening, for example, incorporating MRI as well as mammograms, and for chemoprevention. In most families with multiple cases of breast cancer and negative BRCA1 and 2 testing, the genetic etiology is unknown and presumed to be polygenic. An associated issue is that once a BRCA mutation is identified in a family, targeted testing, either for the single site mutation or in the Ashkenazi Jewish population, the 3 common Ashkenazi Jewish founder mutations, can be performed. Such an approach significantly decreases the overall cost of testing and should be considered the standard of care. In summary, women testing negative for known familial BRCA1 and 2 mutations should adhere to current population breast cancer screening guidelines. In contrast, individuals and families with negative BRCA1 and 2 mutation testing, despite a strong family history, should be counseled regarding enhanced screening and prevention. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.